So in the first three sections, we talked in detail about the maternal anatomy, normal labor, what are the stages of the normal labor, how we can manage the normal labor, what's the assessment during labor, all that we covered in detail. So now in this section, let's begin with what's the abnormal labor. And in the abnormal labor, we will talk about the patterns and management of abnormal labor, what's the pelvic disproportion and malpresentation, and the Bishop score. So pattern of abnormal progress in labor. Here, if you see, this is a very good graphic description of the normal labor and what are some different abnormal labors. This is the cervical dilation, and then we have the time of the labor. This is the normal, in which we have the latent phase and then the active phase of the labor, latent and then active phase. Normal labor. Then in this bluish color line, this explains the secondary arrest. If you see the first stage of the labor, the latent phase is normal as the normal phase, latent phase, but in the second phase there is arrest of the progress of the labor here. Then the yellow line, it gives the primary dysfunctional labor, and then primary dysfunctional labor, there is no latent and active phase, it's one straight line. So it's dysfunctional labor. And then the red is prolonged latent phase. If you see, the latent phase is prolonged in this case. So these are three very important or good examples of the abnormal patterns of the progress of the labor. So prolonged latent phase in the here, prolonged latent phase in the red line, prolonged latent phase. This is common in primiparous women. Primiparous women are the women who is their first delivery. So usually in the first delivery, the first stage here, the latent phase is prolonged. They have prolonged latent phase. Usually when they feel the pain and contraction begins, because it's their first pregnancy, they hurry to see the doctor, or they come to the clinic. But on a vaginal examination, the cervix didn't start to open up, or there is no effacement. So usually the obstetrician send them home back and tell them that it will take some time. So in primiparous, or in the first pregnancy, this is the prolonged latent phase. There is in primary arrest, secondary arrest. This is the secondary arrest here after, and then the primary arrest in the first stage. And then there is arrest in the secondary stage. So all these are different abnormal patterns of progress in the normal labor. Primary arrest, secondary arrest, the first phase progress normally, and then there is arrest in the second phase, and then there is arrest in the second stage, which is the stage after the complete dilation of the cervix, the delivery of the baby, as there is delay in that phase. So these are the abnormal patterns of progress in the labor. Management of abnormal labor. Poor progress in first stage. If there is poor progress in the first stage, there is dysfunctional uterine activity. There are not good powers exerting. We talked about these three P's of the labor, and the first P was the power, and the power was from the contraction of the uterus and the forces exerted by the mother. If there is poor progress in the first stage, usually it's due to dysfunctional uterine activity, and the powers exerting on is not forceful enough or good enough. So poor progress in the first stage here, there is poor forces or poor powers exerted. That's the graphic representation of dysfunctional uterine activity. Then number 2 is cephalopelvic disproportion. Here we have another 2 P's. Passages are not good enough and passenger. So there is disproportion between the size of the head and the size of the pelvis. That is causing delay in the progress of the normal labor. So cephalopelvic disproportion. Flexed and extended. So here if we measure the different things, attitude, well flexed, less flexed, partially extended or deflexed, extended brow presentation, and hyperextended face presentation. Diameter suboccipito-bregmatic, occipito-frontal, occipito-mental, and submento-bregmatic. And measurements are 9.5 centimeter in well-flexed baby. In less flexed or occipito-frontal diameter is 11.5. Then occipito-mental is from the chin to the occiput is 13.0, and then 9.5 again in the submento-bregmatic. These are the diagrammatic presentations here. This is the well-flexed baby here. The first is well-flexed, and it's from suboccipito. This is the occiput, and this is bregmatic, suboccipito-bregmatic diameter, which is 9.5 centimeter. Then in another case, this is we have occipito-frontal. Frontal is for the forehead, occipito-frontal position. It's less well flexed, not as well flexed, and diameter is 11.5. Then in this case, we have occipito-mental. Mental is for the chest, chin from occipito to, this is the occiput, and then this is the occipito-mental presentation, it's 13 centimeter, and then there is submento below the chin, submento bregmatic, again is 9.5 centimeter. So depending on what's the presentation of the fetus and how big is the pelvis, and if it's letting the baby go out easily or not, it's important. So that's called the cephalopelvic disproportion. If the pelvis is big enough to let the baby go out. And this is from flexed to extended position. In this submento-bregmatic, you can see the head is fully extended, so, and the diameter is 9.5. So all these from flexion, less flexion, and extended position. Diameters are different, presentations are different, and depending on what's the measurements of the pelvic outlet, then the delivery should be managed accordingly. Cephalopelvic disproportion. Anatomical disproportion between the fetal head and maternal pelvis. Obstructive hydrocephalus, if there is hydrocephalus in which there is enlargement of the head because of accumulation of the fluid, cause macrocephaly or macrocephaly, in which the head is big and it has problem in coming out. Fetal thyroid and neck tumors may cause extension at fetal neck. Malpositioning of fetal head relative lead to cephalopelvic disproportion. So all these are different conditions that can cause cephalopelvic disproportion and difficulty in the process of delivery. Malpresentations, some malpresentations, we have poor labor progression. If the presentations are not, the progress of the labor is poor. It can be brow, face, shoulder, breech presentation. So brow is the head presentation. It can be the face presentation, shoulder presentation, and breech presentation. Often in multiparous women, so positions malpresentations are more common in the women who have multiple deliveries. Shoulder presentation cannot deliver vaginally, they should go for C-section. So all these presentations are malpresentations, brow presentation or forehead, if there is brow, and then there is face presentation. If there is shoulder presentation, breech presentations, all these can have problem in the normal vaginal delivery, especially shoulder presentation should not be delivered normally. Poor progress in second stage. Again, second stage of labor is from the complete dilation of the cervix to the delivery of the fetus. So it's poor progress in second stage, imminent delivery, secondary dysfunctional uterine activity due to android pelvis and due to resistant perineum. If perineum is resistant, it's hard, muscles are not soft, they are not relaxed, that can also lead to poor progress in the second stage of labor. If there is android pelvis, we talked about the shapes of the pelvis. Gynecoid pelvis is more broader. It can have it can give easy access to the delivery of the baby. Android has little poor access. Then we have, if there is secondary dysfunction, uterine activity, all these can lead to poor progress in the second stage of labor. Fetal compromise in labor. Fetal compromise can be due to different risk factors. Some of these are if there is placental insufficiency, fetal growth restriction, and preeclampsia, that's common cause of fetal compromise. Pre and post maturity, multiple pregnancies, prolonged labor, cord prolapse. Cord prolapse is very common cause of fetal compromise in labor. Cholestasis of pregnancy, oligohydramnias, maternal pyrexia or any infection like chorioamnionitis, intrapartum abruption, augmentation with oxytocin, hyperstimulation, and maternal diabetes. All these are risk factors for fetal compromise in the labor, and fetus should be assessed properly if these conditions are present, especially the cord prolapse is common, and then if there is intrapartum abruption is separation of placenta from the uterine wall. If there is diabetes, oligohydramnias, multiple pregnancies, the careful monitoring of the fetus should be done. Management of possible fetal compromise. If there is fetal compromise, it should be managed by IV fluid resuscitation, fluid bolus, vasoconstrictor like ephedrine should be used. Tocolytic drugs are the drugs like terbutaline that slows down or that quiescen the uterus and decrease the contraction of the uterus. Left lateral position. Left lateral position of the mother is very helpful in relieving the pressure on the different vascular structures to improve the blood flow. Turning off infusion temporarily. If there is any oxytocin infusion for the labor, that should be turned off temporarily. So all these are the steps for the management of fetal compromise. Now what's Bishop score? Bishop score is, it quantifies how far process of labor has progressed prior to induction of labor. So if the induction of labor is done, it's a score that tells how far is the labor is progressed and what next should be done for the labor. High scores of Bishop score can lead to the delivery, makes the delivery easy, short induction process and less chances to fail. If the score is low, the induction period will be long, there is more chances to fail, and usually it leads to C-section. So Bishop score is important to find out how we should manage the process of the labor and whether the induction of labor will succeed or no. These are the Bishop scores 0, 1, 2, and 3. We should look for these 5 things: dilation of the cervix, consistency of the cervix, length of the cervical canal, position of cervix, and station of presenting part. These 5 things should be measured to find out the Bishop score. So dilation of the cervix, for if it's 0, then the score is 0. For 1 to 2 centimeter, the score is 1. 3 or 4 centimeter score is 2. For 5 or more, the score is 3, which is the good indication. Consistency of the cervix, firm is 0, medium is 1, if it's soft is 2. Length of the cervical canal, if it's more than 2, it's 0. 2 to 1, it's 1 score, and 1 to 0.5 is 2. So length of the cervix, the bigger, the poorer will be the outcome. Position of the cervix, if it's posterior, score is 0. If it's central, score is 1. If it's anterior, score is 2. Station of presenting part. -3 is 0, -2 is 1, -1 or 0 is 2, and if it's below the ischial spines are the landmark for the measurement of station of presenting parts. If it's below the ischial spines, then the score is 3, which is the good indication. So all this constitute the Bishop score, and that helps us to find out how far the process of labor is progressed. So that was all about section 4. Thank you for watching sqadia.com.